Professor Pablo Artal from Murcia to give the first presentation about the physics and what's behind the idea. So Pablo, please.
I'm in southeast Spain, in University of Murcia, and well, as you know, it's very common that cataracts and macular degeneration are together in many patients. And for a very long time, and I believe it's still there is a kind of open question that, by the way, I will be addressing in more detail in one of the sessions at 3. It's what is the benefit of having cataract surgery in AMD patient until now? And actually, from most of the literature review is basically modest. So there is some improvement, but it's in average no more than 6 letters. So this is a kind of a little bit frustrating for many patients, because probably the expectation of having a cataract surgery and not gaining much vision is a little bit frustrating. This is basically the standard with normal IOLs today. Actually, I wanted to verify this, and I did an experiment that it's easy to understand, but I'm going to be quick. It's what is the relationship between cataracts that produce scatter light and vision in the periphery? You know that AMD patients basically are using the healthy areas of the retina. And what we discovered with this experiment is that in the central fovea, for a patient with a normal fovea, when you correct scatter, when you remove cataract, there is a very significant improvement in visual acuity, as you know, so it's very successful. However, in the periphery, when you really correct cataracts, there is an improvement, but it's very modest. So this is in very good relationship with the situation in the clinical evidence. So for those patients having cataracts and AMD, doing cataract surgery is okay, and this is something that I believe you should do it, but unfortunately, the visual benefit for the patient when you remove the cataract is modest. So this is basically the background. And as you know, AMD patients basically use these peripheral healthy areas. And you know this is basic physiology, right? If you are using your central fovea, you can reach a standard decimal visual acuity 1. But if you go only 3 degrees, you decrease so much. It's 0.3, and if you go 10 degrees, it's less than 0.2. So there is a very significant decline in resolution with this patient, and this is basically what it is. And on the other hand, and this is just coming more into the details of the optics of this lens, in each eye, the optics in the periphery is getting worse. And this is not a big problem, because actually we don't need it, because in the periphery our resolution is poor, so it's not very important that our optics is not working very well in the periphery. However, we also did some experiment years ago that visual acuity is really affected by optical blur also in the periphery. So this can be a little bit confusing, but the message is, in your peripheral area in this patient, you can improve the optics, and you can then improve visual perception. And this is basically the whole idea of this new IOL for AMD. It's simple, and it's going to be more presentation about the lens itself and how to use it. It's as simple as a single lens. So this is very different from other approaches for AMD, as you know, can be kind of relatively invasive with a couple of lenses, big incision. Not here. This is just a very simple lens. With a wide-angle design, what this means, we want to have good optics for the areas that these patients are using. And we are also providing a little bit of magnification, but this is when it's in combination with external spectacles. And this is the lens that we call Eyemax Mono. These are the lenses that actually we design. And very simple again, the idea is these lenses, they have a specific profiles, a specific shapes, a specific optical properties to basically optimize the quality for the peripheral area that these AMD patients are typically using. This is the only trick, let's say. This is some simulations that we did some time ago, just showing what's happened with a standard monofocal when the image is going from the center of the fovea to the periphery. You see there is some degradation. And we can compare with what we are doing here. Basically, there is also some degradation, but it's smaller. So we keep good image quality in the near periphery, and this is what's happened for near objects. So I think this slide is comparing. These lenses provide a more sharp image in the periphery and a little bit bigger. This is for distant, this is for far. So we are providing relatively small magnification. So there is two issues here. We are providing a little bit of magnification, but helps the patient, and we are getting better optics with this design. So this is basically the concept. It's going to be more data that I'm sure you like to hear about what is going on in the clinic. We have also our own data that very preliminary results that we are doing in the university clinic, and actually I need to give the full credit to Dr. Jose Maria Marin, that he left this morning actually. He was here over the weekend, so he did basically these surgeries. We are doing, I have data here for 10 patients bilaterally, and these are the details. And basically, and this is very consistent, I believe, with the results with other investigators. This is basically showing you for distant and for near the average result for 10 patients, and comparing the black is before surgery and the gray is after surgery. And these are basically for right eye, left eye, and binocular. And so you can see there is a significant, and this is in Lockmar, this is basically high contrast visual acuity. So we have a pretty significant increase in visual performance. These are the individual results, so this is also something important I would like to point out. There is a kind of individual results. So you get some patients with very significant visual acuity gain. There is other patients that they are gaining very little. We don't have any patient that it's doing worse after the surgery, but it's kind of depending. We are ordering here in terms of the pre-op visual acuity, and basically those patients, and I'm sure this is going to be more in details in other presentation, but those patients that they have a very poor, they are in the kind of advanced stages of AMD, the benefit is not so good. So I should say that we get the best benefit. In some cases, incredible, very good benefit, more than 20 letters, so really very good, in those patients with some kind of intermediate stage of AMD. So just to conclude, I would like to remind you, and I open for questions after in the discussion, that this is basically a new concept. We are not doing prismatic effect, we are not doing telescopic things. So it's a simple, we want to be simple. That was our main, I like this. Simple is beautiful, right? It's kind of, this is what's our idea. And trying to get the best image quality as possible in the periphery, helping for this patient. And so far, the good thing is that this is very simple surgery procedure, as normal as any standard one. And I think with this, I would like to thank you for your attention. And as I mentioned, very happy to take questions in the discussion. Thank you.
Okay, thank you very much.